would like to invite up Dr. Ghassan Wahbeh. Dr. Wahbeh is the director of the Inflammatory Bowel Disease Center here at Seattle Children's, and we're very glad to have him here talking about healthcare maintenance or pediatric inflammatory bowel disease, maintaining good health. Please join me in welcoming Dr. Wahbeh.
Thank you very much, Kathleen, for this kind introduction. And I'm glad to see everybody here today, and it's always a pleasure to speak at all of our patients' events. So my topic today was how to maintain good health, and I know part of it was also trying to help our families tell apart what's IBD and what's not IBD, since a lot of non-IBD stuff could happen in everybody's life. But I always like to start with with any conversation about IBD, that we treat the IBD and we treat everything about the body, mind, our patients as a whole. So a big picture goal of treating our kids, inside out. And one big segment of that is treating the IBD. What does treating the IBD mean? I think that's a picture that is always on my mind every time I see my kids in clinic. I want to get to these goals, and I want to get to all of them, and I run through the list every single visit. So IBD treatment, the goals are clear. We have to get into remission, and remission means no symptoms that are attributed to IBD, normal growth, completely normal growth, complete normalization of the blood test, because that is one very powerful measure of inflammation, not on its own, but one of the many things, again, that we want to restore back to being normal. Having a normal bone density, and we'll talk about that in a couple of slides. And also making sure that our patients are developing psychologically and emotionally, and they're moving with their social life. These are big, important goals as well. And when they're productive, when they have jobs, to be able to make it to that job, uninterrupted. And achieving all of these goals without steroids, without repeat steroid use, and healing of the lining of the intestine. So these are the clear treatment goals that are on my mind every single time. And achieving all of these goals as early as possible, is also a key thing. I think it's always better to shoot for these goals within the first year of diagnosis. So I'll start by talking about the diet. I know that Dr. Lee gave you a talk about diet early on today, and he certainly is teaching us a lot about what to look out for. But I thought I should mention this because I think for most of our patients who have excellent control, excellent remission with their IBD, diet seems to be one common thing that disrupts that regular health, the normal health. And I kept it simple here, that we have to keep up with the fruit and vegetables. That's the simplest, most straightforward recommendation that I would give not just my patient and their families, but my neighbors, my friends, my brother, my parents. So 5 to 7 portions of fruit or vegetables a day. And as you may have heard this already, the historic recommendation of avoiding fiber or avoiding raw vegetables or raw fruit has been really demystified, and it's really a myth to ask a patient not to have fruit or vegetables. We want our patients to have fruit or vegetables, and there is evidence that their health is better when they have their share of fruit and vegetables. More plant protein and less animal protein, that's generally healthy with IBD and for every non-IBD chronic human condition. And that's heart disease, stroke, blood pressure issues, and diabetes. Less refined sugar, which you heard about, and then a diet modeled after the specific carbohydrate diet, but not necessarily strict in my opinion. So these are the key guidelines that it comes with the diet. This one is the food. It's not a pyramid, obviously. It's a circle, a pie chart, I guess. The food pie, if you will. From Harvard Medical School, which I think is a lot better than our FDA recommendation. It really balances everything out when it comes to consumption of different beverages, with clear focus that milk restriction should be considered. And restriction does not mean zero, but limited quantities of milk and limited quantities of juices. So I just put it up there. Again, I don't want to go over the same content that my colleague did earlier today. When we ask our patients, and you saw this also earlier, when we ask our patients what are they eating, this was the map of what patients are eating. More calories, much higher protein than their bodies need, less fruit and vegetables, and quite a bit of additives. And these additives are in frozen dessert, ice cream that you buy from the store, and even prepared foods. And for every patient, there was about a 5 count of additives in their diet on a daily basis. So just to give you an idea about why I think diet is an issue, and we know that diet could cause symptoms on a day-to-day basis. So let's move on to the bones. How do we maintain healthy bones? Well, the way it goes for our bodies is that with time, since we're born, we accrue more and more bone strength, which is the bone density. And this gives us the good skeletal strong frame that we live with afterwards. And you see this curve going up from birth, and the maximum is hit around about age 20 or so. And then all of us start to lose bone density. And this process could be very limited by IBD. IBD could slow down the bone density. It could limit the bone density strength. So instead of ending up here, it could end up here. And it accelerates the bone density loss, or the weakness of the bones. So how do we take care of our bones with IBD? Well, the biggest thing that causes the bones to weaken is inflammation. So that's why I go back to that slide number 1 and say, these are the goals of treating the inflammation, and I want to go through that and achieve it for every single patient, every single visit. The second is repeat use of steroids or prednisone. And again, 1 course, maybe 2 courses is not what I'm talking about here. It's the 2 courses a year, a course that lasts for 6 to 10 months above a certain dose. So there are a lot of effects that we want to avoid from the steroids, but for some patients, 1 or 2 limited courses of steroids are not what would cause the bones to be weak. Now, low physical activity, and we know with patients who have active inflammation that could restrict their physical activity. We know that patients who have who have active inflammation may not be able to participate in sports. They might feel weaker. The muscle mass could be weakened if their nutrition is poor. But for patients who are in remission, it's important to emphasize that physical activity, and physical activity does not have to be complicated. We're not talking about jujitsu here, or climbing, rock climbing to certain heights. Any physical activity that contracts the muscles, jogging, swimming is good, biking, stationary bike will do the job. So any process where we have some tension, where the muscle contracts in the body, ideally 5 days a week, ideally 30 to 40 minutes or more a day. That would be the ideal exercise level that we would want to see, and that stimulates the bones to get stronger. So even if the inflammation is controlled, our kids need to exercise to get more and more bone density in. Certainly the dietary factors, vitamin D and calcium, are important. They're part of the big picture for bones, not everything. So you can be on top of the vitamin D level, be on top of the calcium intake, but without good inflammation control and without good physical activity, the body is not going to utilize the vitamin D and the calcium to build more bone density. And certainly if there's a strong family history of bone weakness, that could run in that particular family. So that's one factor, but that's not often the case. So how do we keep the bones healthy? Again, back to inflammation control. You're going to hear me say this very often throughout these 30 minutes. Avoiding steroids, balancing nutrition, exercise, we talked about that. And my rule about exercise is that if the inflammation is controlled, and again, that's the goal that we shoot for, then there is no reason attributed to IBD why our kids could not participate in some form of exercise. They may have their preferences, everybody's entitled to their opinion, but as Ashley would know, I would not give an excuse for my kids, and I have to say, I've almost never had an ask from my kids not to exercise, even when the Crohn's is active. So I think we should emphasize that exercise is part of everybody's healthy routine and should be there daily. And last but not least is bone density monitoring. So you'll see your provider ask for a bone density check every now and then. I'll talk about the gums, how to maintain healthy gums in IBD. There are multiple causes of gum inflammation in IBD. One of them is the Crohn's itself when it's active, and this is what a Crohn's ulcer could look like in the gums. So if the inflammation is active with Crohn's disease, it could be any part of the body, and the gums are part of that. Certainly, if there is active inflammation or extreme diet restriction, vitamin deficiencies could cause some gum inflammation. Diet, especially diet high in refined sugar. We think maybe even the sweeteners, artificial sweeteners could affect the teeth in a negative way as well. Dental hygiene, so just like anybody else, with or without IBD, we need to remind our patients to take care of their teeth, see their dentist as well. Steroids, again, frequent courses, prolonged exposure could also affect the gums and the health of the teeth. Sometimes it's habit. We've had some patients who bite their gums, and we talk about how that is probably not a good idea. Easier said than done, but these habits are, in many ways, habits that need to be traded for something else. You can't just ask any individual to stop the habit. They have to exchange it with something else. Singing the ABCs or one favorite song or Despacito or whatever our kids like these days might be a better idea than gum biting. So how do we keep them healthy? We go back to inflammation control, avoiding steroids, toothbrushing and flossing regularly, multiple times a week for flossing, avoiding refined sugar, we talked about that, and then seeing the dentist regularly, twice a year seems to be a good idea. We often get asked the question of can our kids with IBD have any dental procedure, and what are the precautions around that? If the inflammation is well controlled, which we always aspire to have, then there should be no limitation on what dental procedures can be done. Sometimes it's fine-tuning, timing of a certain medication, but otherwise there's no contraindication to having dental procedures done. So I'll talk about the skin. There are IBD-associated skin conditions, fancy names here, erythema nodosum and pyoderma gangrenosum. And these are very obvious, skin spots that can be painful. And that's not the scope of my talk to go into those today. There is one key thing that we always keep in mind, that with IBD, there may be a slight increased risk of skin cancers. Now, we all know that skin cancer is a major issue in North America. Especially if any of us are not very tanned. If we're not very tanned, we're susceptible to the sun rays, and since the skin is, where the sun ray hits, the overexposure to sun rays, especially with sunburns, heightens the risk of skin cancers. Whether IBD itself adds to that risk, it's a hypothetical scenario there. And we haven't been able to prove exactly how much would IBD add to the risk of skin cancer. We know certain medications like azathioprine or 6-MP could add a bit of a small, again, very small risk of skin cancers. And it's important, just like any individual out there, especially in Seattle, when the sun, or if the sun comes up, we know that we have to not go overzealous and let ourselves get sunburnt. So use of sunscreen is always a good idea. Now, we also come across some rashes that could come up with the treatments, and some of the treatments are like infliximab or Remicade or Humira or adalimumab. And this is what some of these rashes could look like, usually some redness and scaling around the edge of the scalp. Unfortunately, we can treat those skin infections with different topical treatments. It's uncommon that we would have to interrupt the underlying therapy to address the skin issues. And then allergies that could come up with medications could cause different rashes. So not very common that our kids get skin manifestations of IBD or complications of disease, but I think biggest, simplest advice would be to use sunscreen, and if you see something fishy, just let your provider know. there are common things that happen to everybody. And again, we get asked a lot about these. But eczema, one of the most common things that human beings have. Pilaris keratosis, which is a very fancy, very fancy term for dry skin. And ringworm, which could happen. We don't think that our medications may heighten the risk of these infections. Molluscum, which is a tiny multiple skin bumps with a little dot in the middle. And these are viral infections that could happen with everybody. Again, nothing specific to IBD. Sunburns, oftentimes we get a fancy looking rash, but turns out it's a sunburn, but the t-shirt was fancy, so that's why it looked funny. And then we talked about skin cancer, which could be with or without IBD. I dedicated a couple of slides here to talk about the joints, because that's also a common thing that comes up. So with active inflammation, about 1 out of 5 kids could develop joint inflammation. And joint inflammation is different than just a joint ache. Joint inflammation is when the joints are stiff, swollen. Sometimes they look red. They feel warm. And that's true arthritis or inflammation of the joint. And they could be in different joints, whether it's what we call the peripheral joints, for example, the wrists or the ankles, or they could be the axial joints like the spine. And most of these underlying active joint inflammatory conditions go hand in hand with the bowel inflammation. So if we are on top of the bowel inflammation treatment, the joint inflammation often is not there. Enthesitis is a variation of this inflammation, and it's exactly where the muscle meets the bone. And that's sort of around the joint, and it's called enthesitis. That's part of the inflammation that could happen with IBD. Now, again, if the inflammation is well controlled, fortunately, we don't see much of this type of inflammation. However, we have to keep in mind that our kids could get multiple aches of their muscles and of their bones, and some of these are actually common and normal. One is what we know as growing pain. An example of that is the Osgood Schlatter, and again, fancy name for there's a bit of tension on the knee because the leg is stretching out. The other part is ankle, foot, and knee aches. Oftentimes what I see is if there is physical activity, especially during the growing period, it seems to make these pains a little more intense. A bit of stretching before exercise might be all that it takes, and a bit of reassurance might be all that it takes. When it comes to some knee symptoms, foot and ankle symptoms, the most common cause of these that I see in my clinic, and it's a very good thing, is that my kids are overgrowing beyond their shoes. So if they keep up with good quality shoes, proper size shoes, the pressure that goes up from the foot to the knee and to the hip gets better distributed, and these pains fortunately go away. So very simple things, very common things. It actually makes me happy when I see some of these things, because that means my kids are growing and they're exercising. So 2 good things, and the pain does move on. Back pains, most often reason why I see back pains in clinic is muscles. Posture seems to be a big issue for a lot of teenagers and adults, mine included, my back included. And I think posture is something we have to focus on. Back exercises, stretching, yoga would be a great idea. And if patients are able to incorporate that in their day-to-day exercise, I think it would be a very good investment long-term in their healthy backs. I'll move on to the eyes. Just like the joints, certain types of eye inflammation could come up with IBD. The terms are uveitis or episcleritis or retinitis. What it means for a patient is having eye pain, sometimes losing the acuity of the vision, so seeing blurry objects even with proper lenses, and retinitis, which could also present with visual field deficits. So these are, important symptoms that we take seriously if we hear from our kids. Fortunately, when the inflammation is well controlled, again, we don't see inflammation beyond the gut. So eye inflammation goes hand in hand with gut inflammation. Sometimes patients, and unfortunately we don't see this because our drive as a center is to really limit the use of steroids, but you see this in much older individuals treated with IBD 40 years ago, 30 years ago, where the repeat exposure to steroids can result in having cataracts or glaucoma or increase in the eye pressure. Unfortunately, we don't see this hardly at all. We have good studies that looked at the incidence of eye problems in treated IBD, and that seems to be way less than 3%. So if you notice something in terms of complaints about seeing clearly, complaints about eye pain, I think a simple visit to the ophthalmologist will give us a good answer there. So keeping the eyes healthy, we go back to avoiding steroids. Nutrition can help with the eyes. So either a well-rounded diet, or if there are some restrictions, considering vitamins on any diet that our patients want to follow. It's always a good idea to work with our dietitians, and they do a fantastic job analyzing where the deficits could be and making sure that our kids are supplemented. And they have wonderful expertise with IBD. And then screening. The general recommendation is seeing the eye doctor once a year, and certainly, as I said, if there are symptoms, seeing the eye doctors a little more frequently. I bring this up, and I know this was talked about. I don't want to overstep the next speaker here. Getting stares. Is that why you sat in the front, to give me stares with anybody else seeing? Okay, thank you, Ashley. But I bring this up because I think a lot, as human beings, a lot of how our feelings go dictates how our bodies feel. In other words, symptoms of anxiety, symptoms of depression could be reflected in back pain, muscle pain, weakness, fatigue. So I bring this up because I don't think I could separate this from any talk about routine health maintenance. To me, that's a big part of the body. It may not be part that is a solid part, but it is a huge part of our day-to-day life. We know that 1 out of 3 kids could have symptoms of anxiety and depression. It's part of the inflammation. And fortunately, a lot of this could ease off when the inflammation is treated, but also when we help our kids deal with the different emotional stress and challenge that comes with IBD. And again, without going into too many details about that, because that'll be the next speaker. Now, certainly, these symptoms of anxiety and depression are not easy to recognize. I've never had a patient who walks in and says, "Hey, I'm 11, I have Crohn's disease, and I have anxiety." It doesn't happen like that. We have to ask, we have to search for clues for that. Sleep is a big issue that we think is abnormal in 70% of all of our patients with IBD. And certainly medications like steroids could make these symptoms worse. So just a few lines about this. It's always important to know, whether you're a patient or a parent, that IBD is nobody's fault. Nobody could have caused this, or nobody could have prevented this. That's really important to know. It's also important to know that, as incredible as parents can be, dealing and recognizing symptoms of anxiety and depression is not expected, from a parent. Again, as astute and caring and excellent observers that parents are, you need a third party to work on this. You need a professional to work on this. Somebody wants to be good at tennis, they get a tennis coach. And unless you're the parent who's a tennis coach, which trumps my point here, that's a good idea to go to that specialist and work with them on these issues. Now, sleep is a big, huge deal. And sleep, just like anxiety and depression, or with anxiety and depression, could add to the body symptoms: fatigue, weakness, sometimes diarrhea, sometimes constipation, abdominal pain. And these are the symptoms of IBS, or irritable bowel syndrome. And certainly medications could be sometimes needed to address, even if it's transient, the anxiety, depression, or sleep disorders that could happen. Social activity, again, I bring that as part of the health maintenance. Happy child is a child who's interactive with their family, with their friends, who's playing, who's going to school. And IBD can certainly be isolating because of the symptoms, because of the unknowns that come with it, because of the restriction in growth that could come with untreated IBD. And again, it takes me back to my goals of therapy. I want my child to grow as much as their potential is. And certainly anxiety could limit the child's ability to participate there. So a bit about vaccines. So vaccines have really a huge role in maintaining health. And I can tell you from a provider side, when I see a child with some infectious complication that I know could have been prevented by a vaccine, it's just a reminder of how important of an investment that is. The ideal time to really push for a good set of vaccines will be probably the day that the first endoscopy confirms having IBD. There's a window during that time when we start either nutrition therapy, or there's a bit of a 1 to 2 week periods where we wait until we get some more results. That's the time that we would want you to work with your general provider and obtain any vaccines that are due, and also consider optional vaccines that we think add a lot of value in preventing infections. These are the pneumonia vaccines, type 13 and type 23, the hepatitis A vaccine. I think most individuals have it nowadays, the HPV vaccine, and the meningitis vaccine. So oftentimes you'll see us meet with you right after the endoscopy and say, these are the vaccines that I would want to get. If that doesn't happen at that point in time, that's still okay. For these vaccines, we can actually give them after being on therapy. The one thing with being on therapy is that our patients with most therapies, most medications, could not get live vaccines, because we think there's a small risk. It's a very small risk, but it's a risk nevertheless of having a side effect from the vaccine. So main thing to take here from vaccination is, yes, we do believe in the value of them. Ideal time is to try to get any vaccine before therapy. Even after therapy, that's still okay and there's still benefit. The annual flu shot is a good idea. And if there are any questions, it's easy to nowadays to, Google question about vaccines, or call your nurse and provider, and they can get you the answer there. Sometimes you'll see us check how successful the vaccine is, and that's with hepatitis B vaccine and with the chickenpox vaccine. I think I have 1 or 2 minutes left, but I thought this was important to talk about, which is over-the-counter medications, cough syrups, Tylenol, what to do with those. I think the ones that I want to focus on are the non-steroidal anti-inflammatory medications. And these are the ibuprofens, the Motrins, the Advils, Aleve, not the Tylenol or acetaminophen. And historically, there's been a big overhype about how these could flare IBD. But now that we know that it's not just a blank statement, it's actually frequent use, multiple times a week, multiple weeks a month. That's when you see the risk of a flare go up quite a bit. Now, what we tell our patients is that if the IBD is well controlled, so that remission that we talked about, slide number 1, that limited use of ibuprofen is okay. For example, with period-associated pain, it is okay to use for a day or two some Motrin or Advil. A headache that didn't respond to Tylenol, it's okay to take some Advil for a day or two. If this is becoming once a week and 4 weeks a month, then I think that would be a concern, and I would want to know, why is that headache happening once a week, right? That's a more important question in my mind. But the occasional use is safe and should not have any patient or parent toss and turn at night. What about antibiotics? I would keep in mind that antibiotics save lives. Antibiotics prevent deafness from untreated ear infections. So if there's a clear need for antibiotics, I think they should be prescribed and used. I think if there's uncertainty about whether this active infection warrants an antibiotic or not, it's always a good idea to say, can I wait a day or two and see how things go? So most providers are very sensitive and aware of the overuse of antibiotics in general, but I think it's always a good idea to have a conversation. If you have to have the antibiotic for a good reason, it's an excellent reason to take it. If there's a question mark, then I'd rather have my patient wait a day or two and then see how things go. We don't have a preferred type of antibiotics. Sometimes using probiotics with the antibiotics can minimize diarrhea as a side effect. I do think if our patients' diets are well balanced, there may not be a need for a probiotic. And probiotics on their own in IBD have a very, very limited role. I know sometimes, it feels like we need to do more. We need to supplement more in our patients' day-to-day routine. But when it comes to what would be scientific data, probiotics have a very limited benefit. And I would say it's specific patients who've had surgery after ulcerative colitis, and that's when probiotics may come in handy. Otherwise, maybe a short course of probiotics with antibiotics that patients take for ear infections or strep throat infections. So in summary, I think the key point to me is excellent inflammation control is the best way to bring that body back to good, excellent health. Diet plays a huge role in IBD and also beyond IBD. So keep the diet simple and keep it tasty. I think a miserable diet is not worth it, regardless of what that diet is. But also keep in mind that diets, certain things in our diet could actually cause or worsen the inflammation. And then keeping in mind that, our patients' health is beyond IBD. They get everything that any other healthy, happy child would get. And I would keep that in mind as well. But we have an open channel with our patients, with our families. Always stay in touch. I'd rather have a parent call than toss and turn about a question. And as many of you know, we could also do the portal through the web where you can communicate with us and we can message back and forth. And usually we try to get the answers within a good, 24 hours or so. And I'll stop here. Thank you.